to do half an hour each. Since Dr. Punamia has to attend to Delhi for some meeting, I think he wants to do first half an hour. May I call upon Dr. Kirti Punamia to present his complications, and I would like to make it a more interactive session. So halfway through, I think we may intervene and ask questions to make it more interactive. And I would encourage the audience to raise your hand and ask questions. Dr. Kirti Punamia.
To see my slides. Hello? Hello?
Yes, we can see.
Okay, great. So if you can see my slides, I think what we're going to do is, first of all, Dr. and the Sri Lankan Cardiology Association, thank you so much for inviting me on this podium to speak with you. And today is an extremely interesting topic, very dear to me, because these are lessons that I've learned, and complications happen when you're doing complex cases. And I have my regrets, and those are a few. I have many regrets, but on occasions I've been able to reflect on some of these and make changes in my practice, and I'm going to share some of those with you. In 2006, many years ago, we'd got this man with complete heart block, cardiogenic shock, and we put in a pacemaker in him, settled him, he did okay, got it back for a planned angioplasty. This was post-bypass surgery for a left main intervention. And in those days, we used to do the classic crush. So with a Cypher stent, we got a stent into that LAD and large circumflex, so kept a stent in the circumflex, completed the job, and this was the result. However, you can see that there was a little bit of undone over here, and we didn't have IVUS in those days at all in our cath lab. So because we didn't have IVUS, we thought that we should go ahead and dilate that proximal part of the stent a little more. And lo behold, we had a balloon which had a pinhole rupture. This is what happened to the left main, and we lost that patient. So this was where we realized that not all interventions go as well as you will plan them, as well as you can plan. There can be a disaster. And for me, starting off as a cowboy, this was a humbling episode, and I call this the humbling of a cowboy. And it happens to just about all of us. This is a gentleman who is a young fellow who had a STEMI with cardiogenic shock as well, was recovered after prolonged medical management. This was triple vessel disease. We had a CTO. So we thought we have a high-grade complex lesion in the LAD, and we have a totally occluded RCA. So maybe we should do the RCA first. So we took him up for an RCA PTCA. Here's it. We did this RCA. We crossed it. This was some of the pictures there that you can see. We crossed it with one of the CTO wires, and once the wire crossed, you can see very well that we had a fine cross catheter would not advance, and the Tornus 2.1 catheter would not advance. This was, again, a few years back when we did not have an excimer laser. At this present time, we would have chosen an excimer laser for this indication. So anyway, we were able to get a rotor wire distally, and so we went in and did a rotational atherectomy in the mid-segment. Once we completed that, this was the flow that we got. We had opened up the artery, and now we had this distal lesion, which was right there at the crux. You can see there's a PL branch, the PDA, all looking upward. And we thought this should be simple. We'll dilate it, put in a wire in the PL branch, put in a stent, and then stent all the way and complete the case. This is what happened. So we then, to kind of get material downstream, we then pacified the proximal part of the lesion with a long stent. We then went and chose a balloon to there was a very large PL branch, so it was essential to kind of keep that under control. And there we had a balloon which was undilatable for that lesion. At 24 atmospheres, a 2.5 balloon just would not expand. We tried that. We tried an OPN balloon at 30 atmospheres, and it would just not yield. And then with this, what do? we'd already ruptured this. Can you see what has happened now? With that opium balloon at 30, we had a rupture distally, and this was a problem. How do I seal it? I'm not able to cross it with any of the high-profile devices. We're not able to expand it, so there's no way I could put in a covered stent or anything across. So what do? In a desperate attempt, I went and took my rotational atherectomy, which was already opened, and I said, let me do a rotational atherectomy distally. When I tried to do that, what happened was this burr got stuck here. And when the burr was stuck and I withdrew it back after putting my guidezilla and cutting it and chasing it out, this was an occlusion. The whole artery occluded. And this occlusion was the first time when an artery occluded in my cath lab that I said it was a blessing. I counted my blessings. But what was my plan? My plan was to cross with a wire, no other device crossed, use a rotablator, and then a proximal stent was placed, undilatable lesion, opium balloon, and then a rota. Where did I go wrong? I think the first mistake I made was if I did use a 1.5 burr initially, instead of just restricting to the mid RCA, I should have gone and run my burr downstream, and that would have been a better strategy, at least in this case, because I might not have had a stuck burr, because my stuck burr was more from the dissection planes and the slow flow and the no flow and the heat burring up. That's what caused it. The second mistake I made was I ruptured the artery at a very high pressure using a slightly higher size balloon for that occasion, and I should have restricted to 2 or 2.5 balloons, not to the 3. And then my third mistake I made was I went in a desperate attempt to do a rota when I had already completely dissected that artery, when I should have just gone ahead and occluded that artery with a wire and just given up that case at that time. So I guess many mistakes to learn from. And so now let's talk about how often do you get a stalled burr. Stalled burr happens in around 0.5% of cases. And this case was approximately 6 years ago. And cases that have happened, a stalled burr is a one that cannot be activated. So the burr cannot be activated, it cannot be moved forward, or it cannot be retracted. So it's just stalled in the lesion. It is stuck in the lesion. And most commonly occurs with a 1.25. In our case, it happened with a 1.5. More common at lower speeds than higher speeds, and deactivates. So suddenly there's a deactivation of the burr, or the most common reason is that the operator who's doing it actually gets his foot off the pedal and the burr stalls in the lesion and then is unable to activate it. I think this is one of the most important. How do you prevent this? I choose a 1.5 burr. I go to much higher speeds, around 200 or 210,000 revolutions per minute. I do not force my burr through. I just make sure that the burr finds its way and make sure that there is enough interval between two runs for the burr to cool down. We also got to make sure that there is flow. Whenever there is no flow into an artery, or there's slow flow, or there's a total occlusion, you've got to make sure that there is a saline wash which cools out the burr and the lesion both, because if it doesn't, then it can coagulate the lesion or the soft tissue and it gets stuck between the wire and the burr, and therefore it doesn't run. This is a garden variety of a mid-LAD calcified lesion. You can see that just after the diagonal branch, there was a long calcified lesion. A colleague of mine, a very senior colleague of mine operating, chose to use a 1.25 burr. And what happened with a 1.25 burr? He went into that 1.25 burr, and very soon he found that his burr was stuck. Now, this is another example of a stalled stuck burr. And what did we do? This is what we did. At 1.25, 180, notice that when he was doing the first run, he had actually, look at that first thing, the guide catheter backing up. He's actually applying too much pressure. And then when the burr is stalled, the entire guide catheter gets sucked in because he's trying to pull the burr back. Two mistakes, because when you do this, the guide catheter dissects the entire proximal LAD. So what do we do? Under the circumstances, the best thing to do is cut the shaft of the burr shaft, discard the plastic sheath, then load a guidezilla right to the burr tip, and then with that, tug on this whole system. And when you tug on this whole system, you will see that the burr comes out And then you're left with an artery which has a little bit of a dissection. Most of the time, these are our stuck burrs where we pulled out. You notice that partial dissection, type 1 perforation. You can see the proximal dissections in certain places. And often enough, when you pull these burrs out, it brings out a bare around amount of tissue along with it, almost like an atherectomy or part of the artery. And this is very scary. This is what we were left behind with. We still had that calcified lesion to deal with. So once we had got it out, we took in a 1.5 burr, completed that job. This is the final run after we completed the job and stented that area, and this patient did well. So how do you prevent a burr stalling? Rule number one, most of the burrs that have stalled are 1.5. So rule number one is Wercross burr should be 1.5, in general, a larger burr. Do not advance the burr aggressively until the RPMs drop. So you've got to prevent the RPMs from dropping. So too much pressure on the burr is going to encourage a burr stall. So if the guide catheter backs, remember, rule number 2, that's too much pressure being applied on the burr. The guide catheter should not move in its direction when you're doing a rotational atherectomy. In dense calcium, all our stalled burrs have happened at a lower speed, 160 or 180 RPMs. We have gone up to higher speeds. I don't put that as a rule because a lot of people in the world still do rotational atherectomy at 160,000, though I start at 190, go to 210. And once I've finished my pass, my first pass, I come back to 120,000 and do a slow run across the lesions now for a better ablation or a better tissue ablation. The second thing is to keep the burr moving and engaging the lesion for long runs. And when you do that, you heat the burr and it coagulates the tissue, causing it to jam. So rule number 3 is even if the burr does not seem to advance, do not force it. The heat will modify the plaque enough and it may dilate now, especially in underdeployed stents. Having said that, let me go to what is a stuck burr. A stuck burr, again, a very infrequent complication, happens when the burr cannot be activated beyond, however, cannot be retrieved. So the burr can go forward beyond the lesion, but there's a certain point in that artery which it cannot be retrieved from, and that is a stuck burr. Most commonly happens when you direct it in dissected segments, non-coaxial guiding catheters at the ostium of the right coronary artery, and trying to push through a lesion when the burr daughters through it without ablating, classical. So these are the lesions: osteolarcia, diffuse disease, and bends, acute bends. This was a diffuse lesion where the operator attempted to do a balloon dilatation, was not able to advance the stent because of the heavy load of calcium. And he attempted many balloons, failed to expand, failed to dilate, or failed to advance a stent inside. He gave it up, and this was the artery. 4 days later, I was involved in that. And so we took in a 1.5 burr, went in gradually through the dissection planes. And what did we find? As we got there, because of the Kokesi effect, there was a point that we could not retrieve our burr beyond this point. The last thing one should do is we should not pull the burr. Because if you pull the burr, the guide catheter goes in, and when the guide catheter falls in, you see that the flow will go down. Right now, with my guide catheter out, when I take a picture, I still have blood flowing down the artery, which is a good sign, which means that there is not going to be any great ischemia happening as long as I don't tug on the burr. So here, what I did was, this is the phenomena. Happens in eccentric lesions. This is your wire. And when you do a rotational atherectomy like this, you create a soft area, and the wire then digs into the plaque, and it goes to the inside of the plaque. And therefore now the whole shaft of the burr is within the plaque, and the burr is at the distal end. So what I do is I put in my second wire, which goes into this corner. Therefore, what happens is when the burr tries to come back, the shaft gets pulled out because of the sheer diameter of the burr, and that's what happens. So how did we get this out? You can see that we advanced a grand slam wire besides the burr into the distal artery. And when we did that, all we did was activate the burr, and the burr got out of the groove and came back. We then completed the case, stented it, and we got a great result. So basically, there are many ways to get out of this trouble. A lot of people switch to Dynaglide, pulse activated, shuffle slightly, pass a parallel wire, a short balloon to dilate the site, and then pull it out. So there are many ways to deal with this. However, the one that I've mentioned has got me out of almost 6 occasions in my own cases, as well as in my colleagues who have been stuck with it. And we are very happy with the technique that we just suggested. But for this technique to work, the flow has to be maintained, and it has to be a stuck burr which could activate distally but doesn't come out beyond a certain point in the artery. That's important. It's very different from a stalled burr. Moving the context here, this is an 84-year-old man with a bifurcation lesion, if you see in the LAD, right there. Calcified bifurcation lesion, extremely calcified. You can see this is the Medina 111. And there's also a very proximal lesion and a distal lesion in the RCA, which is very tortuous. So our area of interest is the LAD. So this is the LAD lesion. You can see the bifurcation lesion, extremely eccentric plaque in both the ends and heavily calcified. So we did a rotational atherectomy into both the branches, once the LAD into the septal branches and then into the diagonal branches. And when we went in with the diagonal branch, the patient noticed that there was a chest pain. This is the perforation we had. You can see that there's a huge amount of staining outside. And with the stain, we were not sure whether the perforation was proximal at the carina or it was distally into the segment. So what do? The first thing we do is we dilate that area. We dilate it. We then end up doing a kissing dilatation. We end up putting a long stent, and we performed a culotte technique. We stented the diagonal branch first. This is what we got. We went in then subsequently and completed the bifurcation stenting. And once we completed the bifurcation stenting, you can see that it's looking much better. But there was a little dissected plane at the distal end, which we corrected by putting a small piece of stent there. Now, this looked quite good at this present time. So here we are. The chest pain had settled. The ischemia was taken care of. The patient's blood pressure was 100 by 70. And look at what happened. At the start, the heart rate was 70. Now it was 90. At start, the blood pressure was 150. Now the blood pressure is 100. And this is with a low dose NORAD going on. So this is significant hypertension. So we got an echo in the cath lab. And when you look at this angio, it looks like everything seems sealed. So it looks like we've got a great result and there's no reason to worry. But once you do a pericardiocentesis and decompress the pericardium, you will see that the leak starts again. That's because the tamponade effect of the pericardial effusion is gone. So it's very important to do a pericardiocentesis and then repeat a check angio to see that there's no leak. Because if this is the leak, then we have to fix it. So how do we fix that? Now we know that the leak is in the shaft of that artery and not at the carina. So what we do is we expand those arteries higher pressure. And then once we have a 3O balloon to expand it, we then create a bed. We put in a guidezilla and take a guidezilla right into the site. And with that, we then have a Jograph stent, which is 2.5 by 19, coming into that through the guidezilla. And you can see that it gives us an ample opportunity to do a precise placement of the graft. And once we've done that, the extension is extremely useful for a smooth passage with precise positioning of the covered stent. This is our final result. This patient did well, and we had an opportunity to do a 2-year follow-up angiography on him, and all his arteries are looking good, and so is that perforated artery looking good as well. As we get into complexity of lesions, you can see that this is an extremely complex scenario, who had a acute renal failure as well on a background of unstable angina. And this was the proximal lesion. You can see this is a nasty lesion, very calcified with MR, with pH, and with LV dysfunction. So here we are, the left ventricular end-diastolic pressure was 25, and a very, very calcified left main and LAD. Our plan was to first place an impeller and do a 1.5 and a 1.75 and open up that LED. So we placed an impeller. Once we placed in an impeller, we did a 1.5 millimeter stent, a rotational atherectomy, followed with we did an IVUS, and then did a 3.5 OPN balloon dilatation. Our plan was somehow flawed because after the OPN dilatation, you can see that there's a rupture in the artery. So this 3.5 OPN balloon had ruptured the artery. Now we go back and we look again and we see that there's a consistent hypotension. So we get an echo in. And once we get an echo in, we go and complete our angioplasty to maintain the patency of the vessel. And at this time, once patency is maintained, we're not worried about the impeller support anymore. So we can, at this stage, stop the heparin infusion and sacrifice the impeller. And we were hoping that this stenting will seal off the leak. But as we go ahead, even after that seal, we realize that there continues to be a leak. And this leak is torrential because this is causing a pericardiocentesis, and there's gathering of fluid because you can see that consistent tachycardia. And this did not go up because of the beta blocker, but there's a differential, there's a definite hypotension again, and hemodynamics are important. So here we've sacrificed the impeller and we put in a covered stent, and you see that we've covered the seal, we've sealed the entire perforation without any problems. At this point, we can see there's fluid in the pericardial space, even on fluoroscopy. So we plan for a pericardiocentesis. Look at the hemodynamics. We are getting hypotension, and then once we get this pericardiocentesis done, as we get it, we find that there's a rapid increase in blood pressure, and this rapid increase in blood pressure is associated with a rise in the pulmonary artery pressure as well, which means that RV and LV both filling well and contracting okay. But in spite of repeated aspirating from this pericardial space, we had almost got around 4 liters of blood out and auto-transfused it. We continued to have rapid collection to a point that we dropped the pressures to around 35. At this stage, we had no choice, but there was something else going on. So in the cath lab, I opened the chest with a sternotomy. This was a very crude sternotomy because my surgeon was still around 15 minutes away and we would have lost this patient. And you can see that we had perforated the right ventricle. When I take off my thumb, you can see the right ventricular perforation. My surgeon now came in, he sutured that and helped me correct it. You can see that the right ventricle is sutured. And with the open chest, you can see the gauze piece in the thorax. We confirmed that our coronary arteries were sealed and perforated completely, And even after relief of that pericardioscentesis, we make it a point to make sure that our artery seal is complete. We did that. And then so what was the problem? Why did this happen? I think when we look at our IVUS, this is our IVUS. It's a large artery, and we thought that this was a 3.5 millimeter artery, and therefore we chose a 3.5 millimeter balloon because the landing zone was around 3.0. This was a 4.3 vessel with a 3.5 lumen that we wanted to achieve, and therefore we chose a 3.5 OPN balloon. But what we did not factor was this eccentric calcium with a normal artery on this side. Since this case, we realized that whenever we see this kind of eccentric calcium protruding and a normal segment outside, which is even over here, we undersize, and I should have taken a 3.0 OPN rather than 3.5. And I think that was a mistake. My oversizing the OPN caused the problem. And if I have to do this case, I would do it exactly the same way, except that I would have used a 3.0 OPN. Post-suture, and we closed it. The patient's fine. 7 days later, you can see the sternotomy mark on this lady. We were able to send this patient home. This is my surgeon who I have to thank for coming in and helping me suture the sternum together. And this could not have been, this save was not possible without an entire team effort of all my staff. Moving on to, I don't know how I'm doing with time. Do stop me at any point and ask me, would you like me to show some other complication, or would you like me to stop here?
answer a few questions, whatever you have presented up to now.
Yes, please do that. Go ahead.
While people ready for questions, I just would like to answer you now. You said the most common with 1.25 burr. But we find many instances the vessels are really critically narrowed with heavy calcification. 1.5 burr doesn't go down, so therefore we have to take 1.25. Why? What's the reason that it gets stuck like that? I mean, of course, we take basic precaution not to push it hard. You just let it go smoothly. Why do you say it's 1.25? Because the vessel you have shown was about 2.5, 275. Basically, what we do is we half size the burr. If you 3, we try to take 1.5, 2.5, we take 1.25 like. I just don't understand why you want to take on 1.5 only, because when the vessels are critical, the burrs won't track down. What do you say, Dr. Kirti?
So, that is the common belief, but that is not true. The problem is with the 1.25 burr, the way the shape of the burr is, if you look at the 1.25 burr, it's more like an elongated tube. And if you look at the front leading edge of calcium, when you see the ablating edge, there's a very small ablating edge at the front end of the burr. Most of the ablating is at the side. So typically, because it's a small burr, it's very easy to dot it through the burr. And when you dot it through the lesion, you've not really done anything to the calcium, and therefore it's more likely to get stalled or stuck. In the 1.5 burr, or when you get into the larger burrs, they don't get stuck and stalled, they just don't cross. So 1.5 may have trouble going across a lesion, but it is very unlikely that it is going to be stalled in the lesion as long as your speed is good and you don't impact it into the lesion. And not just me, the world over, people who do more than 100 rotobladers a year, which we end up doing almost 110 rotobladers a year, we realize that 1.25 burr is almost less than 2 to 3% in my practice. And often enough, for a long time, when the 1.5 does not go, we take a 1.25. And even if it is a very diffusely small diseased artery, up to the mid-LAD, up to the second diagonal branch of the septal branch, it's easy to use a 1.5 burr. In a circumflex artery, up to the second OM, it's okay to use a 1.5 burr. And right coronary artery, right up to the crux, it's okay to use a 1.5 burr. In fact, we don't need to use a 1.25. The only time we use a 1.25 burr in our practice now is when I have to do a rotational atherectomy through a guidezilla because of a proximal tortuosity of an artery. And that is because the 1.25 is the only burr that will go through that tortuosity.
The tortuous vessel with heavy calcification. What precaution? Usually their wire bias can cause dissection and perforation of the vessel. What precautions you take when you try to do a very angulated vessel, particularly right coronary artery?
So there are, the right coronary artery is the most nasty artery of all those lesions that you may say, and I think that. As we get into the complex right coronary arteries, we also need to modify our techniques. And we've seen some of our cases, especially in the complex right coronary artery, the rotational atherectomy, the wire bias, often causes us to have an exiting of the normal path. That means the wire goes out, the normal artery is there, and the wire goes away from that artery, causing a neolumen. For the short of time, I would have shown you cases where we have studied these very extensively, and all this, when a rotaburr goes outside the luminal space and you feel that you're in an extraluminal area, it still is within the external elastic lamina. It's not outside the vessel, because it's very difficult for a rotoblader to go beyond the vessel unless you jerk it and hit it head on into the artery. The burr jumps. So we've been able to stent it at low pressures without any problems. and tortuous right coronary arteries, sometimes we have to use a guidezilla support for the proximal tortuosity so that we don't have slow flow.
Second case where the diagonal rupture. You used a bare metal stent to... Okay.
So the diameter of the artery was 275.
So
But-
can you use a normal stent in that situation? How frequently could you use that?
No, I didn't quite understand the question. Sorry.
Regarding your second case, when you have diagonal perforation,
Yeah, with a rotablator. Yes.
you used a bare metal normal stent to cover the perforation. Correct?
Yeah.
How
So
frequently?
first I use a normal stent to basically seal the dissection, because whenever there is these kind of things, when you have in that particular patient, there were two things happening. One was the perforation, which is going to cause you a pericardial tamponade and therefore a hemodynamic consequence. And the second thing that is happening in that patient simultaneously is a very large LAD, which is becoming ischemic, and you're getting ischemic infarct, which is going to cause LV dysfunction and therefore hemodynamic consequences. So very quickly, the operator has to make a choice between correcting ischemia first or settling out the hemodynamics first. In that particular case, I thought it was important that the ischemia was far more crucial than the hemodynamics. And so I quickly, in the next 2 minutes, completed the Q lot. And once I had completed the Q lot, the ischemia bit had settled down. Now, all I need to do is, if at all there's a hemodynamic consequence, all I had to do was a pericardiocentesis, which would have taken care of the hemodynamics, and then completed my sealing of that perforation. Because it's only when I put in my stents that I could locate where the perforation was. And I think that was crucial for me. And that decision to decide to chase ischemia or the perforation is very crucial in the cath lab. Was I audible there?
Yeah, perfect. I think they heard you well. Excellent talk. I think nobody can give a rotablation talk more better than this. I think we are audible to outside also. We need to be careful. Can I, Wazira, can we start the next lecture or what is?
All right, okay. Keith, then thank you very much for your nice presentation, and we'll try to contact you in future for further lectures. Thank you very much, Keith. Okay.